I want to start with a number that should make every American stop and ask how we got here. $300. That's what a single vial of insulin costs in the United States right now, up from $40 just a decade ago. And if you're not diabetic, if you don't know someone who depends on this medication to stay alive, you might think this is just another story about rising healthcare costs, another complaint about pharmaceutical companies. But what you probably didn't hear is that the same vial of insulin costs $35 in Canada. Not because Canadian insulin is inferior or because Canada subsidizes it at taxpayer expense, but because Canada regulates drug prices in ways that prevent the kind of price gouging that's become routine in American healthcare. And here's where the story gets much bigger and much more consequential. The pharmaceutical companies that spent decades operating in both countries, selling the same drugs at vastly different prices depending on which side of the border you lived on, are now making a choice. And that choice isn't to lower American prices to match Canadian ones. It's to relocate their most important research, their most advanced manufacturing, their most valuable intellectual property to Canada. Because when American policy became hostile to any form of price regulation, when it treated pharmaceutical companies as untouchable regardless of how they priced life-saving medications, it created conditions where operating in Canada became more attractive than operating in the United States. And the human cost of that shift, the families going bankrupt to afford insulin, the patients dying because they rationed medication they couldn't afford, the communities watching their local pharmacies close because they can't compete with Canadian prices, that cost is already being paid. It's just not being counted. Let me be clear about what officially happened. Trump eliminated the few price control mechanisms that existed in American healthcare, calling them government interference in free markets. He attacked Canada's pharmaceutical system as unfair competition, claiming that Americans were subsidizing drug development for the rest of the world. He made importing cheaper medications from Canada more difficult, framing it as a safety issue, even though the drugs were manufactured by the same companies to the same standards, and he positioned the pharmaceutical industry as a jobs creator that deserved protection from regulation, not an industry that needed oversight to prevent exploitation. These moves were supposed to encourage domestic pharmaceutical manufacturing and protect American innovation. But the mechanics of how drug pricing actually works reveal something very different. Pharmaceutical companies don't set prices based on manufacturing costs or research investments. They set prices based on what markets will bear. And in the United States, where government is prohibited from negotiating drug prices for Medicare, where insurance companies pass costs to patients, where bankruptcy from medical bills is normalized, companies can charge whatever they want. In Canada, where government negotiates prices collectively and sets limits on what can be charged, companies make smaller profit margins, but they still make profits. They still operate. They still invest in research. They just can't engage in the kind of predatory pricing that's become standard in America. Now, if you're sitting at home wondering why pharmaceutical pricing matters beyond your own medication costs, here's the connection. Healthcare expenses are the leading cause of bankruptcy in the United States, not because people are reckless or irresponsible, but because essential medications cost so much that even insured families can't afford them. When insulin prices rise from manageable to catastrophic, diabetics face an impossible choice. Do you pay rent or buy medication? Do you feed your kids or fill your prescription? Do you take the full dose your doctor prescribed or ration it and hope you don't end up in the emergency room? These aren't hypothetical dilemmas. These are daily realities for millions of Americans. And when pharmaceutical companies relocate to Canada, when they prioritize research and development in facilities where price regulation creates predictable markets rather than volatile profit-seeking, American patients lose more than just access to affordable medication. They lose the industrial capacity to produce it domestically, the research infrastructure that could develop next-generation treatments, and the leverage that comes from having pharmaceutical manufacturing as part of your national economy. Here's where the deeper story begins to take shape. Mark Carney saw an opportunity in Trump's hostility to price regulation. While American policymakers treated pharmaceutical companies as untouchable, insisting that any price control would stifle innovation, Carney asked a different question. What if companies actually preferred predictable regulation over volatile markets? What if researchers wanted to work in environments where their innovations would reach patients rather than being priced out of reach? What if manufacturing facilities functioned more efficiently in systems where government coordination reduced waste rather than in systems where profit maximization drove every decision? So Canada didn't just maintain its price controls, it enhanced them, creating even more transparency and predictability. And then Carney made an offer to major pharmaceutical companies. Locate your research and development in Montreal or Toronto. Build manufacturing facilities in Canada. Align with our regulatory framework. And in exchange, you get guaranteed government contracts for medications, streamlined approval processes coordinated with European regulators, access to a highly educated workforce, and a political environment where healthcare is treated as a public good rather than a battlefield. Pfizer was the first to move. Not publicly, not with press releases, but quietly shifting advanced cancer research to Montreal facilities. Then Moderna followed, relocating mRNA vaccine development to Toronto. AstraZeneca opened new manufacturing plants in Vancouver, and each move was rational from a corporate perspective. In Canada, they could develop drugs knowing that approval processes were stable and coordinated with Europe. They could manufacture medications with access to reliable energy and infrastructure. They could recruit researchers from around the world without the immigration complications that had become routine in the United States. And they could operate without constant political attacks on their pricing, as long as they worked within Canada's regulatory framework. For the companies, this wasn't about ideology, it was about reducing risk and accessing markets more efficiently. But for American patients, it was catastrophic. And let me bring this back to the human level, because behind every corporate relocation are people whose lives depend on what these companies produce. If you're a diabetic in rural Ohio, you've probably been managing your condition for years, carefully monitoring blood sugar, adjusting insulin doses, trying to maintain some semblance of normal life. But when insulin prices tripled, when your insurance company changed formularies and stopped covering the brand that worked best for you, when the pharmacy copay went from $20 to $300, your disease management became a financial crisis. You started rationing insulin, taking smaller doses than prescribed, skipping injections when you thought you could get away with it. You gained weight because you couldn't afford enough medication to process the food you ate properly. Your vision started deteriorating because chronic high blood sugar damages eyes. Your kidneys began failing because diabetes complications compound when treatment is inadequate. And eventually, you ended up in the emergency room with diabetic ketoacidosis, a life-threatening condition that could have been prevented with proper insulin access. The hospital stabilized you, charged you $15,000 you don't have, and sent you home with prescriptions you still can't afford. That cycle, that impossible trap, is the daily reality for millions of Americans whose medication became unaffordable, not because of scarcity or manufacturing constraints, but because of pricing decisions made in corporate boardrooms. Let me tell you about what this looks like in practice. You're Sarah, a 34-year-old type 1 diabetic working as a teacher in Cleveland. You've had diabetes since childhood, learned to manage it, built a life around it. Your insurance through the school district used to make insulin affordable. $20 copays, manageable. But then your district switched insurers to save money. The new plan doesn't cover your insulin brand. The alternative they cover costs $300 per vial, and you need 4 vials per month. $1,200 on a teacher's salary. That's your rent. So you start going to Canada, driving 6 hours round trip to Windsor once a month to buy insulin for $35 per vial. You're breaking no laws. This is legal personal importation, but it's exhausting. You leave at 5 a.m. on Saturday, cross the border, visit a Canadian pharmacy, drive back. 8 hours of your weekend gone. But you save over $1,000, so you do it. Until winter comes and the border crossing becomes dangerous. Until your car breaks down and you can't afford both repairs and the trip. Until you miss a month and have to ration what you have left, and you end up in the ER and the cycle starts again. That's not a failing healthcare system. That's a system working exactly as designed, extracting maximum revenue from people who will die without treatment. For families watching loved ones suffer, the psychological toll is devastating. Parents of diabetic children describe the terror of watching their kids ration insulin, knowing that every skipped dose increases the risk of catastrophic complications. Spouses of diabetics talk about the guilt of not being able to afford medication that could prevent suffering. Adult children of aging diabetics face the impossible choice between paying for a parent's insulin or saving for their own kid's education. These aren't edge cases or rare tragedies. These are predictable, preventable outcomes of a system that prioritized pharmaceutical profits over patient survival. And when those same pharmaceutical companies relocate to Canada, when they invest in facilities where medications will be priced affordably and accessible to patients, it's hard not to feel abandoned by your own country's policy choices. Meanwhile, in Canada, something very different is unfolding. In Montreal's biotech corridor, gleaming new research facilities are opening where Pfizer scientists are developing next-generation cancer treatments. The jobs pay well, often over $100,000 for experienced researchers. The work environment is collaborative, with government funding supporting basic research that companies can build on. And critically, researchers know their work will reach patients. When you develop a breakthrough drug in Canada, it gets approved through processes coordinated with European regulators, making it accessible to markets representing over 1 billion people. It gets priced affordably enough that patients can actually use it. And the satisfaction of knowing your research translates into lives saved rather than profits extracted is professionally meaningful in ways that working in purely profit-driven environments isn't. For Canadian communities hosting these facilities, the transformation is tangible. New restaurants and shops open to serve the influx of highly paid workers. Housing construction accelerates. Schools hire more teachers to accommodate growing families. This is what economic development looks like when it's based on industries that serve genuine human needs rather than extracting maximum revenue from desperate patients. Walk through Montreal's biotech district today and the contrast with declining American pharmaceutical hubs is stark. Modern glass towers house research labs where scientists from around the world collaborate on immunotherapy, gene therapy, personalized medicine. The cafeterias buzz with conversations in a dozen languages as researchers discuss breakthrough approaches to diseases that have resisted treatment for decades. These aren't just jobs, they're careers with meaning, work that matters, opportunities to contribute to human welfare while earning comfortable livings. The surrounding neighborhoods reflect this prosperity: boutique coffee shops filled with researchers on laptops, restaurants offering cuisine from every corner of the world because the workforce is genuinely international. Childcare centers with waiting lists because young families are moving to Montreal for opportunities, public transit expanding to serve growing populations, universities adding faculty and programs to meet industry demand for trained graduates. This is the ecosystem that forms when pharmaceutical investment flows toward a region, when companies choose to locate in places offering stability rather than chasing short-term profits in volatile markets. And the workers benefiting from this transformation aren't there because they're exceptional. They're there because Canadian policy created conditions where pharmaceutical companies could thrive while serving patients rather than exploiting them. The key actors in this story made decisions that reveal fundamentally different values about what healthcare should be. Trump and many American policymakers treated pharmaceutical companies as job creators deserving protection from regulation, even when those companies priced medications so high that patients died from inability to afford them. The logic seemed to be that any price control would reduce innovation, that companies needed unlimited pricing power to fund research, that market forces would eventually make medications affordable. But none of those assumptions held up to scrutiny. Countries with price controls didn't see reduced pharmaceutical innovation. They saw companies operating profitably within regulated frameworks. Companies didn't need predatory American pricing to fund research. They chose to extract maximum profits because they could, not because they had to. And market forces didn't make medications affordable. They made them progressively more expensive as companies realized desperate patients would pay anything to stay alive. Carney and Canadian policymakers took the opposite approach. They treated healthcare as a public good requiring regulation to prevent exploitation. They set price limits based on what medications actually cost to produce plus reasonable profit margins. And they discovered that pharmaceutical companies, given the choice between volatile American markets and stable Canadian regulation, increasingly chose stability. Now let's zoom out and look at the broader implications, because this isn't just about insulin or one medication. This is about the entire architecture of American healthcare and what happens when it's designed around corporate profits rather than patient outcomes. The United States spends more per capita on healthcare than any other developed nation, but it has worse health outcomes, lower life expectancy, higher infant mortality, and millions of people who avoid medical care because they can't afford it. That paradox exists because American healthcare is structured to maximize revenue extraction at every point. Hospitals charge astronomical prices because they can. Insurance companies collect premiums and deny claims because profits depend on taking in more than they pay out. Pharmaceutical companies price medications based on desperation rather than costs, and patients caught in this system either pay whatever is demanded or go without care. When pharmaceutical manufacturing relocates to Canada, it exposes how unsustainable this model has become. Companies can operate more efficiently in regulated systems than in profit-maximized ones. Researchers produce better outcomes when they're not pressured to prioritize shareholder returns over patient benefit. And communities benefit more from healthcare industries that serve public health rather than extracting wealth. Think about what this means for American families beyond medication costs. When local pharmacies can't compete with Canadian prices, they close. When they close, communities lose accessible healthcare services. Elderly residents who could walk to neighborhood pharmacies now need transportation to distant chain stores. Patients who had relationships with pharmacists who knew their histories now interact with rotating corporate staff. And middle-class jobs for pharmacists and technicians disappear. Those losses compound when pharmaceutical manufacturing relocates. Construction workers who would have built new facilities, technicians who would have staffed them, engineers who would have designed processes, all those opportunities move to Canadian communities instead. And tax revenues from corporate facilities and worker income flow to Canadian municipalities rather than American ones. For workers in what remains of American pharmaceutical manufacturing, the trajectory is bleak. Companies are reducing domestic production or relocating entirely. The stable, well-paying jobs pharmaceutical manufacturing once provided are disappearing, replaced by automation or nothing. Workers who spent careers in the industry, who developed specialized expertise believing their skills would remain valuable, discover their entire sector is reorganizing around a different country's policy. And unlike factory closures in other industries where workers might retrain, pharmaceutical manufacturing requires such specialized knowledge that displaced workers often have nowhere to go. The 50-year-old formulation chemist who loses his job when a facility closes can't easily transition to another field. His expertise is valuable, but only in an industry increasingly located elsewhere. The structural analysis reveals something profoundly troubling about American economic priorities. For decades, the assumption has been that corporate freedom produces optimal outcomes, that removing regulation allows innovation and efficiency to flourish. But pharmaceutical pricing demonstrates the opposite. Unregulated markets didn't produce affordable medications or accelerated innovation. They produced predatory pricing that killed patients and enriched shareholders. Companies didn't invest profits from American price gouging into breakthrough research. They bought back stock and paid executive bonuses. And the innovation that did occur often happened in university labs funded by taxpayer dollars, then got licensed to companies that privatized the gains while socializing the costs. When Canada maintained price regulation and American policymakers eliminated it, Canada didn't lose pharmaceutical investment. It gained it, because companies discovered that operating in a stable, regulated environment was more profitable long-term than chasing volatile profits in an unstable one. What makes this particularly devastating is how preventable it was. The United States didn't lose pharmaceutical manufacturing because American researchers were less talented or facilities outdated. It lost because policy created conditions that drove companies elsewhere. Every time lawmakers blocked Medicare from negotiating drug prices, they signaled companies could charge whatever they wanted. Every time regulators allowed price increases, bearing no relationship to costs, they confirmed exploitation was acceptable. Every time politicians attacked Canadian price controls rather than adopting similar frameworks, they made clear patient welfare was subordinate to corporate profits. Canada didn't have to work hard to attract pharmaceutical investment. They just had to provide what American policy refused: regulatory certainty, price stability, and a framework where healthcare served public health rather than shareholder returns. The consequences will compound for generations. When pharmaceutical research concentrates in Canada, the next generation of breakthrough treatments gets developed there. Patents get filed under Canadian jurisdiction. Manufacturing expertise concentrates in Canadian facilities. Universities training future researchers orient programs toward Canadian industry needs. And American patients, rather than benefiting from innovations developed in their own country, become customers of a foreign pharmaceutical industry. That dependence creates strategic vulnerability beyond economics. When essential medications are manufactured abroad, supply chains become geopolitically sensitive. When research capability relocates, the ability to respond to public health emergencies diminishes. And when an entire industry recognizes your policy environment is hostile to its interests, reversing the exodus becomes nearly impossible. For young Americans deciding whether to pursue careers in pharmaceutical research, the signals are devastating. The cutting-edge work, breakthrough